we'll start with Dr. Manchakanti. Welcome to the program.
Thank you, Randy.
Most people don't know what an interventional pain management physician is. So let's start there. How do you get to see one? And, how do you choose an interventional pain management doctor?
Well, as I explained to you in the past, in medicine, there are many specialties, about 22 specialties and about 110 subspecialties. So these are like primary care physicians, cardiologists, orthopedic surgeons, neurosurgeons, and many others. Interventional pain physicians are educated and trained to treat chronic persistent pain. You should look for an interventional pain physician if you want to see one who has special qualifications such as fellowship training or board certification in pain medicine. A relationship with a pain physician is long-lasting or even lifelong. You should check to see if the physician can make independent decisions or somebody else is influencing their decisions. Also, make sure when a physician leaves town or your insurance changes, you will still be covered. So long-standing, larger group physicians are good, like our Pain Management Centers of America, where we can cover if one physician leaves, you are still taken care of.
So what, and by the way, as an insurance covers everything we're going to talk about today. Is that true, Dr. Manchakanti? Like Medicare, Medicaid, is it, and that's covered?
Right, as long as we perform the procedures which are covered, like I also served on MCAC and also I serve on CAC, so is Dr. Haney. They prepare the LCDs called local coverage decisions. So if that is covered under there, majority of them are covered. There are few procedures which they call them experimental. In those cases, they're not covered.
Okay, tell me about this. I think you explained to me offline one time, we're talking on the phone, that the goal of an interventional pain management doctor, is to avoid drugs and surgery if possible. Is that right? Or traditional drugs or traditional surgery?
Correct. Well, major goal is to make them better. That is, people ask, can I be cured? No. We can improve your functional status. You can lead a productive life. That is the goal. But the next goal is to get as much relief as possible without using drugs, especially the opioids. Okay. But there are some patients where we can't help them with other techniques, and also we have to supplement them with interventional techniques and also the pain medication. So patients need to think about their chronic pain the same way they do about other chronic conditions such as high blood pressure or diabetes. So it is rare that high blood pressure or diabetes is cured. You take a pill today, it helps you all that day, but it's not going to help you 10 years or 15 years. So the same way you had to work with it and to make lifestyle changes. The same thing is true for chronic pain.
You're chairman of this society, and I guess you could speak to this, but what is the goal, the overall goal? If you had to say there's a goal of an interventional pain management physician with a patient, what is that?
Well, as I said, they often ask me, can my pain be cured? Most often the answer is no. Or your pain can be managed so you can lead a productive life. So as I said before, they have to start thinking about this is a chronic pain. It is a multidimensional. We have to apply different things. It is just not the doctor. I tell some of my patients, or all of them, that it is 10% me, 90% you. So I can help to guide you. I can provide some treatments, but rest of it is left to you. Make lifestyle changes, do the structured exercise program, maintain a positive attitude, and move on with the life and have satisfaction with what you have. Look at the positive, half glass full type of thing, rather than just keep looking for more and more, and you never will be satisfied. So success is like a journey. So be happy once you are successful. It is not the end of the life. It is not end of the story. So it goes on. There is no period after success. It is only a comma.
How does a patient, when they go to see an interventional pain management physician, what should they ask? the doctor when they're describing what's wrong with them? Maybe they don't know yet.
Right. First thing they need to understand is chronic pain is very complex. It is not going to go with some kind of operation or some kind of a pill or going to somewhere. It is a very complex phenomenon. So it is very difficult to diagnose and treat. An interventional pain physician can use many, many tools to diagnose the exact cause of your pain. One of the most important tools is the patient himself, herself. It is important that you describe not only where the pain is, but also what kind of pain it is, how it started, and what effect it has on the life. That is the most important thing. This gives an interventional pain physician the clues needed to make an accurate diagnosis and treatment plan. So this, I always try to repeat this old saying, remember, a doctor who cannot take a good history and a patient who cannot give one are in danger of giving and receiving bad treatment.
Okay, very nice. Dr. Manchakanti, in light of all the questions you read, I asked you to prepare a presentation for the group. So let's go to that.
Thank you. This is a great opportunity. I'm going to cover some of the issues related to pain and try to explain. And people are always confused that is chronic pain always a psychological or it is all in your head. Most of the times it is physical, then psychological comes through. But at the same time, that is a myth that psychology has nothing to do with it. So there is a lot to do with psychological and physical, but mostly the physical. So we want to focus on the physical problems and go to the psychological. Today, we want to talk about what is chronic pain and what is the structural basis for chronic pain. So there is the physical and psychological and some of the management options. Recently, about 2 years ago or so, federal government appointed a committee, Pain Management Best Practices Interagency Task Force report. This was actually headed by one of our ACIP members. They came up with the report that these are 5 techniques we can use in managing acute or chronic pain. First one is start with the medication, then restorative therapies. Medication includes all over-the-counter to the prescription medication. Restorative therapies, physical therapy, exercise program, occupational therapy. Interventional procedures, this is where we come from. We are the interventional pain physicians. So we are at 3rd level. When these fail, this is where you look for, even before the surgery. Behavioral health approaches, we talk about behavioral health, but if necessary, we can employ a psychologist or a psychiatrist also for that part. Complementary and integrative health, this is where the other modalities come, acupuncture, etc. So pain is complex, as I was saying. This is the pain. It is not that simple. There are psychological factors, stress, coping, even childhood trauma can affect it. Social factors, cultural, economic, social support system, biological factors. Where is the pain coming from? How is it affected? What does age have to do with it? Or what does gender has to do with it? So there are many of the issues there. There are 3 issues here. Understanding the pain. There is nociception, that is the cause of the pain itself, and modulation. The physical transmission of the pain is the nociception. So something comes and hits you, like a snake bites you. That is the nociception, or something hits. Pain is subjective experience that there is something happening. There is a harm going on. So this is how it works. This is the age-old theory. Here is something happened to the foot, and the pain starts going up. It goes up into the head, and then it comes back. You take the foot away from that area. But there is also a modulation part. It's not as simple as we think. It goes into the brain and comes out, but something else happens in the spinal canal, spinal cord. So there is modulation. It becomes bigger and bigger. That is where this allodynia comes. Allodynia means a non-painful stimulation, like when I touch you, you feel okay. But that sometimes can cause the pain itself. Hyperalgesia is hypersensitivity. So a small needle can look like a big knife cutting. These are the things you go into chronic pain. So see how big it has grown to. This is the modulation. Now, can MRI or CT scan tell where pain is coming from or how much pain you have? Absolutely not. It visualizes the anatomy, but not pain. It can identify anatomic defect or surgical correctable lesion, then they can operate, or even infection. So a lot of times, even patients who do not have any problems or any individuals, not necessarily patients, you go and have an MRI, you can see some abnormalities there. So disc bulging, for example, 80% of the patients with back pain had disc bulging. 52% with no problems walking in the street had disc bulging. 30% had disc protrusion. So disc extrusion is the only thing which is very common only in people who have the problems. So here we do the diagnostic blocks. We put small amount of numbing medication on the nerve. So it tells us where the pain is coming from. That is the pain generator. So with this knowledge, we do the therapeutic procedures to relieve the pain and reverse the symptoms. It also allows time for healing. It facilitates the physical rehabilitation, just structured exercise program, your ability to do your activities of daily living. It also reduces the need for repeated x-rays and sometimes even surgery. Surgery is performed only in 5 to 15% of the patients. Majority of the other people get better with the conservative management and other treatments. So if you look at the spine, there are 3 segments here. The cervical is the neck area. There are 8 vertebral bodies and also the nerve roots and facet joints, 2 on each side. Then you go into the thoracic spine, there are 12 of them, lumbar spine, 5 of them, and then they also have the sacrum. It is about 5 of them. There are 2 types of pain. One is a somatic type of pain, other one is radicular type of pain. Somatic type of pain is the one which comes from the bone, ligament, joint, muscles, and sometimes the disc. Also, there is referred pain. So you have problem in one area here, but the pain is, your feeling is here. So sometimes people get upset. Why are you telling me that I'm feeling pain here? You're telling me the problem is here. This is what the referred pain is. Sometimes it goes into up your head. Major issue everybody says is that, hey, my discs are hurting. I ruptured a disc. So intervertebral disc, that is what is called. It is cervical, thoracic, and lumbar, all 3 regions I just showed you. So disc is different. There are 2 parts to the disc. I will show you that in a second. But a disc bulging this is the disc bulging. Like you take a balloon and keep putting more air into that, it swells, it bulges. That is the disc bulging all over. Whereas if you make a small weak area and then put more air, it produces a limited bulging here. If you really put a small area, that is the focal protrusion, that is what the disc herniation is. That is the most disc herniations we think of. Then you have the disc extrusion. This actually loses the connection with the disc itself, the segment. So this is like a jelly donut. If you look at your disc, it is just like a jelly donut. This white stuff is the jelly inside, and this is the outside donut. So this starts leaking. It is coming out. That is the same thing here, coming out. Then it presses on the nerve, irritates the nerves, and you have the pain, compression or irritation, inflammation. If you look at the MRI, this is how it looks like. It is bulging here. Look at that. It is pressing on your nerve. Radicular pain is irritation or inflammation, and it goes down into your extremity. Radiculopathy is there is some kind of damage to it. There is numbness, weakness, and may not be associated with pain sometimes. So this is how it looks, a picture of a radicular pain or radiculopathy. If your low back is, you have a L4, L3-4 disc herniation, this is how it looks. Lateral aspects of your thigh and goes down into the leg. L5, it is a little bit different. S1, it is a little bit different. So this is all the information we need. So we can diagnose you looking at that. So the same thing happens in the neck. This is a C6 disc herniation. This is C7 disc herniation. So if the C6 nerve root is involved, that is the most common one. Sometimes you just feel the pain just above your shoulder blade. You think that we are crazy telling you that it is coming from your neck. So this is how the disc works. You have the disc here, there is the nerve root, and jelly donut, this is the jelly, this is the rest of the donut, this is the nerve root here. So that starts leaking, starts putting pressure on it, inflammation. There are different substances in the body. They are called phospholipase A2, prostaglandin E, various polypeptides. They kind of, you see how it is lighting up the bulb? So it produces the heat. Sometimes you feel heat when you exercise. That is how this works. They also have joints. It is called facet joint and sacroiliac joint. These are the two important joints in the back. As I said before, there are two facet joints at each level. This is one, and this is the next one. When you facet joints hurt, this is how your pain looks like. In the low back, most of the pain is in the low back and the buttocks. Some pain goes down. Very rarely it can go down below your knee, but this is bony, aching, throbbing type of pain. It's not sharp electricity type of pain. And this is mid-back pain. When the facet joints hurt, this is how you feel. This is the neck. When the facet joints in the neck are affected, this is the type of pain you have. This is the sacroiliac joint pain patterns. Most of it is in the hip and then goes down sometimes as far as your foot. So how do we do these things? When you come with this to a doctor, we follow an algorithmic approach. I will show you how we treat low back pain. Everything else is very similar, but we'll start with the low back pain. You come with chronic low back pain. So it is either somatic or radicular, just based on the history itself. Then we decide where the pain is coming from. Is it facet joint or SI joint or the disc? So we manage it based on that. We can do the medial branch blocks or facet joint blocks. If you are positive with that, we can do the therapeutic blocks for treatment, or we can do radiofrequency. Radiofrequency is where we put heat on the nerves after the block. When we do the nerve block, it probably helps you about 2.5 to 3 months or sometimes 4 months. When we do the radiofrequency, that is the heating of the nerves, it helps you 6 months or sometimes longer. Same thing happens with the sacroiliac joint pain. We can also do the radiofrequency on the sacroiliac joints. For the discogenic pain, generally we give you the caudal epidural or interlaminar epidural, but there are treatments we can treat the disc with. Unless you want to go ahead and have surgery done, there are a lot of surgical modalities too. Then if you have the radicular pain and you're not having any significant problems like losing your bladder sensation, etc., in those cases, it's an emergency, you have to go for surgery. So we start with the epidural injection here. There are 3 types of epidural injections, or we can do the percutaneous adhesive lysis. After that, we can do the disc decompression if necessary. If nothing works and you had surgery and you did good, that's great. If you didn't do well, we can do a spinal cord stimulation or implantable or infusion systems. These are all the interventional techniques we can offer: epidural injections, facet joint blocks, neurolysis, SI joint injections, neurolysis, lysis of adhesions, spinal cord stimulation, peripheral nerve stimulation, intrathecal pumps, vertebral augmentation, and a procedure called MILD. I will just go through these procedures, how we do them and how it is. They are reasonably simple if in a well-trained hands, they know what they're doing. here, this is the lumbar facet joint nerve blocks. We do them usually at 3 levels. In this picture, I'm showing you at 4 levels. That means we are blocking 3 joints here. Generally, we block 2 joints at each level. That means we have to do 3 nerves, 2 joints. And the same thing, we can do the radio frequency. The needles go to the same place. We put the heat on there, and that is the radio frequency. So same thing can be done in the neck. These are the needles in the neck. They are pretty small needles, you see. And then we can do the radio frequency also there. If we are doing a sacroiliac joint injection, this is how we do. We put a needle into the joint and inject the medicine. It clearly shows how it fills the joint. But let us say if you want a long-term relief with this, we can do radiofrequency neurotomy. So we put a needle here, and one here, and then put the heat on the nerves. To look at the epidural injections, there are 3 types of epidural injections. The most common everybody heard of is that, hey, I had one when we had the baby, or my wife had the baby. So that is called a lumbar epidural injection. But this is a lot different. We do it under the X-ray. We see the flow patterns. So this is the lumbar interlaminar epidural. We put the needle towards where the problem is and inject the contrast material. We can see that how that is filling up. This is after the injection of the contrast. If you want to see without contrast, look at this last picture. There is no contrast here. So this shows very good filling pattern into the epidural space. Also shows the nerve roots, you see. They're not obstructed, they're good. So this is where we put the medicine. Usually we put local anesthetic alone, or sometimes local anesthetic with steroids. Steroids do have some side effects, but if we feel like there is significant inflammation, steroid is the choice. If we don't have that much inflammation or long-term patient, only local anesthetic. The next approach is we do the caudal. We just put the needle just above your tailbone and inject the medication. You see, this is how it goes. After that, there is a special one called transforaminal. If we know exactly what nerve root is causing your problems, that is what we focus on. It's called transforaminal epidural injection. This can be done in the neck too. This is the cervical interlaminar. You see, this is the neck part. When you are lying down on your stomach, this is your largest vertebral body, C7. Here is the needle. After injection of the contrast, you can see this, and it is also trying to fill the nerve roots here. The adhesive lysis procedure is very interesting. When you don't respond to that, people think that I don't have any scar tissue. I never had surgery. Why would I have scar tissue? I don't make scar tissue. And some people say that, oh, I make a lot of scar tissue. I have scar tissue everywhere. Either way, you can have scar tissue. A disc can leak and bring scar tissue onto you. But after surgery, of course, you will definitely have scar tissue. So this is how it is. We put the needle at a caudal place, and you look at it. There is no scar tissue here. There is no obstruction. It fills really, really well. But on this side, you don't see that filling very much. So we put a catheter like here and try to push that scar tissue away, free the nerve root, and then inject the medicine. Look at here. It fills the nerve root beautifully and releases the pressure. And we put the medicine there. It should help you for pain problems. If we didn't do that, if we just injected, it never went to the place, it's not going to help you. Then you brand it as a failed treatment. This is how a surgery looks like. This patient had 4 screws put in, and we did this procedure. Look at on the right side, very good filling pattern. His pain is all on the left side. So there is nothing there. So we inject the medicine here after doing the procedure. Look at that, it fills really nicely. And you can see the nerve roots. Spinal cord stimulation. We'll talk a lot more about this during the meeting, the rest of the session. So we put the leads in the spinal canal. This is the thoracic spinal canal. We have the leads here. So this is like T7, T8. That is where we put most commonly. So we thread them in, and if this is a trial, let's say. If it works and you're happy with it, you want to have it done, then we put those in and also put a battery here below your belt or above the belt or towards your stomach. The same manner, there are some patients who don't respond to anything else, so they have the pumps. So that is called the pain pacemaker, and this one is called pain pump. So we have two modalities of treatments. Here we put the catheter into there and put a battery here, a reservoir, and this needs to be filled every 2 months or so. Now, vertebral compression fractures, if you're elderly, we have so many of patients with compression fractures. So these can be treated with balloon kyphoplasty. Look at the balloon is put in there, and then you put the cement in there. There are a lot of medications too we can treat with, over-the-counter medications, prescriptions, opioids, anticonvulsants, antidepressants, and sometimes you can even take steroids. But the most popular medication is the opioid, pain medication. So if you look at the whole world, we always think that, why are these doctors not giving any medications? Why are they so damn worried about this? Look at these numbers. Like United States, per million persons, we have 314.5 deaths. The United Kingdom, only 83 deaths per million. So United States has less than 5% of the world population, but we use 70% of the whole opioids. So there is a reason for them to be worried about. But the good news is that most of the deaths are related to the street drugs, fentanyl, heroin, cocaine, methamphetamine. Prescription drugs are really reducing the deaths. This is the prescription drug deaths. It is coming down, not going up. So we have to go through a lot of evaluation and a lot of thinking before we write the first prescription to you. Initial evaluation, diagnosis, medical necessity, risk-benefit ratio. Then we have to get your informed consent. We initiate the treatment. We continue to monitor you all the time. So that's all, Randy.